Good afternoon. My name is Andrew Bluestein, and thank you for joining us this afternoon for Improving Medical Records and Coding Strategies for Ambulatory Surgery Centers. This is a presentation of Garfunkel Health Advisors, and we have a lot to do. I know this is scheduled for 45 minutes. We lied. It's probably going to be about an hour. Hopefully, you can all adjust your schedules. If not, we will be sending out the slides, and we will also be sending recordings, I think. But GHA, which I'll talk about in a second in the commercial part of the presentation, they spend a lot of time at all types of providers, but with ambulatory surgery centers and diagnostic and treatment centers, and similar institutions, at the core is a consistent problem in medical records. So we thought it would really be good to share with you all some information regarding medical records and strategies for having to deal with it, because it is such a basic building block to prevent future problems, whether it's from a regulator or a payer or from a patient. So I hope you find today's presentation meaningful. Next slide. So before we get into our presentation, though, I want to just tell everyone, you're the first to hear this. This is now, I'm switching from Garfunkel Health Advisors to Garfunkel Wild. We're having our 9th annual ASC and Healthcare Management Symposium on October 25th. It is virtual because I am tired of predicting when COVID is going away. It's free, but we have limited bandwidth. So if you want to register, there it is on your screen, the phone number, as well as an email. And when you get the slides, if you can't write it down now, then you can register tomorrow. Okay, so let's go to the next slide. And what is Garfunkel Health Advisors? Many of the people on here have already used them. It's a wholly owned subsidiary of Garfunkel Wild. It's a whole team. I'm very excited that we have 2 of those members on today. But what Garfunkel Health Advisors does is a series of supporting roles for providers, whether it's medical coding and education, or auditing, or payer credentialing. You can read the rest: clinical documentation, revenue management, billing, and operational compliance. It's a very complicated world out there in healthcare. I don't need to tell all the providers that are on here. And so GHA is here to help you. And one product specifically that they offer is they go in and they look at medical records. And it was really reviewing the reports of that, that is a deliverable under the products, that made us realize that we really need to focus kind of in a broad way on medical records. Okay, so what are the objectives for today? Next slide. So we're going to talk about source of medical records. There's no guidance. There is guidance, and we're going to talk about it. We're going to talk about key strategies for efficient coding, and then we're going to have an exciting question and answer with our panelists. That's why we're going to blow our 45-minute schedule. Okay, next slide. So you all know me. I'm not important, but I happen to be the chairman of GHA, so I stuck my slide in here. But the real people that are important is the next slide. The first one is the president of GHI, Alicia Schickel. I've known Alicia for a million years, and we were so excited that she agreed to come over and be the president of GHA. She's a master coder, but not just that she can see a record and see a problem, but she's incredible at explaining and educating. And she's an author and a lecturer, and she has more certifications than clearly I do. And we're very excited that she is leading the charge. She will be the second speaker talking about medical records efficiency. Leading us off, next slide, is Michelle Vander Ark. She also has a tremendous amount of experience. I didn't even know you could be a subject matter expert in chart completion and documentation requirements, but she is. And she has brought to the GHA team just an incredible amount of knowledge. She's also something called, which I never heard of before, a certified registered health information administrator. You will find out by the end of this presentation, especially for those providers who are in New York, why her certification is crucial. I'll give you a little hint, because without that certification, she could not help you meet DOH requirements. Okay, so we're gonna start out with something a little fun. And we're gonna take some polls because we have evidence, as I said, for having gone into providers, but we wanted to poll the providers. So I know there's some people who are not providers, so please don't answer the question. The first one is, how would you rate your center's medical record compliance? And let's be honest, this is a privileged communication. Is it great? We're in good shape. You should press A. B, we're good. We are perfect. We're not perfect, but in good shape. C, we're fair. We do okay, but definitely need improvement. And D, we struggle and compliance is a concern. So why don't you pick which one it is, and then our master computer will be able to give us the results. And this is the first time we've tried this, and my fingers are crossed. And there we are. Okay. That's kind of what I would have expected, that on the two extremes, 7% say you're great. Let's let Michelle crack that and see if that's true. And 50, so more than half of you think that you're in good shape but not perfect. So hopefully we can get you there. 29% are fair. And 7%, I think, are the people who are truly being honest, that you are struggling and compliance is a concern. Again, we hope to help you today and through our future services. Okay, let's go to the next poll. Thank you for voting. If you were audited by CMS, and so this is not what you think, this is what CMS thinks, would you pass with flying colors, pass by the skin of your teeth, fail miserably, and you have no idea? Now, if you don't know the CMS standards, you should be picking have no idea. Because again, it's not what you think, it's what CMS thinks. So everybody vote. And these polls are important because it allows the panelists to kind of gear their remarks. Okay. Let's see what the results are. Okay. I like the ease. You were being honest. You have no idea. That's right. 8% pass with flying colors. I support your enthusiasm. 17 pass by the skin of your teeth. That's right. And I like your 8%. You know the standards and you're pretty confident that you would fail miserably. So, okay. So panelists, take note. Okay, we have only 2 more questions. How often do you have difficulty getting paid because of medical documentation deficiencies? Meaning they're saying, we're not paying you because of X, Y, and Z that's in your medical record. So never, infrequently, or consistently. So remember, this is what the payers think of you. And by the way, I'm not saying the payers are right. It's just your experience. In fact, I would say that most of the times I disagree with payers. And GHA does a good time fighting. So vote, and let's see what the panelists say. What the computer says. Never, great. Infrequently, okay. Consistently, 31%. Right. So that's what we would have thought, right? Okay. All right, last one. And this really goes to culture. Your providers and nurses consider documentation to be a burden and ignore it. And remember, this is providers, meaning physicians and nurses. So it's kind of not a fair, you got to put them together. A burden and ignore it. A burden but complete it because they are forced to. C, an important aspect of patient care. And D, it's both. It's a burden and also an important aspect of patient care. So vote so that we can turn it over to Michelle, who's going to take these comments and be our medical record expert. So let's see what it says. Okay, interesting. Interesting. So I'll just focus on D for a second. They consider a burden, but they realize it's important. So maybe they would, if we did some education with people, they might have an understanding towards why it's required. And so maybe that helps with the burden. Okay, so with that, we all have our instincts going. Michelle, help us with the burden of medical record requirements.
Sure. Those actually were great answers and helps us to understand what your facility might be having troubles with your medical records compliance. And those percentages were not outside of what I have historically seen with facilities who think that they do pretty well and can pass, which is mostly true. And we do have some that fail miserably, and we have some that are excellent with their documentation. I am here to help you better that. Again, I'm Michelle Vanderark. I am an RHIA, and chart completion is my expertise. Documentation standards at times can be complex. And like I said, today we're going to review some of those key documentation standards that CMS puts out for us. As we all know, medical records are the history of our patient's health journey. They are also legal documents, and they are subject to state and federal laws. And medical records need to tell the story of why the patient was presented, their past and current health that may or may not contribute to the issue that they're here today, and the care and services that were rendered to the patient. That documentation must be complete, comprehensive, and accurate. And your ASC must have a system to properly collect and store those medical records, as well as be able to retrieve them at future times. Today, those systems are typically electronic, but they could be a hybrid record consisting of electronic and paper documentation that is scanned into your electronic system. And always, you should review your state's regulations regarding record retention. For those of you in New York, regulation is 6 years from the date of service or hospital discharge date for adults. And then for peds patients, they're 3 years after the patient's age of majority, which is 18. Next slide. There are numerous oversight agencies that put forth regulations for documentation compliance. CMS is considered the standard by which most other agencies base their regulations off, to include multiple commercial payers. Your medical staff rules and bylaws should also reflect your facility's documentation requirements. Next slide. Let's discuss the CMS standard 416.47, which is the medical records condition for coverage. CMS says that the ASC must have a complete and comprehensive and accurate medical record for each patient. You're gonna hear me say those three words a lot: complete, comprehensive, and accurate. Accuracy is very important. You don't want your operative report to mention that your procedure was done on the left knee when it was actually the right. The overuse of copy and paste can also lead to inaccuracies within the medical record. And for that, you want all of your documentation to be complete. If it's not documented, it didn't happen. So gaps in documentation can make it appear that adequate care was not given to the patient. And that can lead to your payment denials. CMS also states that records must be documented timely. There are individual requirements for timeliness based off of document type. So H&Ps, you have to be in the record and updated prior to surgery. Orders have to be signed within 48 hours. The entire record must be complete and closed within 30 days. Complete and closed does not mean coded and billed. That pertains only to your documentation. And as always, ensure that your patient's privacy is kept safe. The only individuals assessing a patient's record should have a need, reason, and permission to be in that record. Your facility's policies and procedures should address those restrictions to access, as well as HIPAA requires your facility to have audit trails in place, and you need to be doing auditing on a consistent, regular basis. Next slide. DMS does have a requirement that each patient has a unique medical record. We do not want two patients to be joined into one medical record. That will pose a privacy breach, billing and coding issues for sure, and obviously improper continuation of care. Each year, the Joint Commission, who doesn't accredit everyone, but they are one of the leading standards, they put out a list of national patient safety goals. And every year, patient identification is number one. Name and date of birth are always the first two suggestions. Those are the two most widely used identifiers, and it sets as the benchmark. Number two is every surgical patient should have a history and physical done within 30 days of the procedure. That has to be in your record. Typically, this should have been done by your patient's PCP. And then that H&P must be updated by the surgeon immediately prior to surgery. Updating the H&P at 7 p.m. from the surgeon's home office the night before does not count as that 24-hour time frame. That surgeon should be laying eyes on that patient while they're doing that update and reviewing everything that was in that history and physical. Next slide. Number three, pre-op diagnostic studies. Those are your EKGs, your labs, and your radiology results. These can also include any PT and OT requirements for medical necessity prior to surgery. Make sure all of those are in your record if they're pertinent to your patient's procedure for that day. Number four is this requirement is in regards to the op report. Alicia will go over in detail why the documentation is important to your payment later, but for now, we're going to review that the minimal required elements are always the name of your surgeon and any assistants that assist, the procedure performed, you want a pre and post-op diagnosis, the techniques of the procedure and the findings, that's your main body of your op report. And then the two of the most missed data elements that I see consistently across the board are estimated blood loss and specimens removed. If there was no estimated blood loss, there was no specimens removed, your provider should be saying not applicable or NA. Just note that it needs to look as if it wasn't missed. If your op report or your OR nursing notes even tells me that there were specimens removed, then I'm going to expect to see that path report later. Again, your rules and regs should govern when a formal op report must be in the record, but best practice and some accrediting agencies call for immediately after procedure, 30 minutes to an hour when that patient leaves the OR suite. If your facility still uses dictation and transcription, then a brief post-op note is required for continuation of care until that op report is transcribed and in the record. We don't want to leave our PACU staff hanging on what happened in that surgical suite. Next slide. Number five, allergies and drug reactions. Those should be addressed in your H&P. And they are also a standard data element within most EHRs. Some EHRs flash allergies across the top of the screen, or they have pop-ups that it just alerts your care team to any allergies. If you're still in paper, it needs to be an H&P. It should be multiple places, truthfully. Number 6, anesthesia administrations. Generally, there are 3 phases of anesthesia care: pre, intraoperative, and post-surgical. The anesthesiologist should really ideally be reviewing that H&P along with the surgeon and adding any additions to that physical exam that he thinks need to be added. The pre-anesthesia documentation should always include vitals, height, and weight, cardiopulmonary exam, and then the one thing that I always see missing from that is your airway assessment. There needs to be an assessment of ASA physical status for airways. The intraoperative report, that's your standard set of documentation requirements for what occurs during the procedure. That's your monitoring, your physiological data, IV fluids, meds administered. Those must include your dose, your time, and how it was given. And then post-op. That documentation tends to be missing most frequently, and it's due to the minimal time that patients spend in the PACU after surgery in the ASCs. This documentation needs to reflect briefly how the patient is doing prior to being discharged or transferred. Even though they're there for a very short time, it's still vital data that we need to have. The surgeon can do this as well. It doesn't have to be the anesthesiologist or the CRNA. Some brief documentation elements are the physiological condition of the patient, preferably a pain level, and any anesthesia-related complications or complaints. Basically, how are they feeling? Are they coherent? Can they be discharged? We shouldn't be discharging home anyone that's not coherent. Next slide, please. Number 7, documentation of a properly executed informed consent. This is important. Your consent needs to have the procedure on that consent that is going to happen, and it should match your op report. It also needs to be signed prior to surgery. It needs to be signed by your patient and your surgeon. Typically, there's also a third signature line for a witness. It's usually your RN that does that, or a surgical tech. The body of the consent usually has standard language that states the surgeon has gone over risk and benefits with the patient about how the procedure will be done, why it's necessary. That information should be reviewed with the patient by the surgeon prior to the procedure being done. If your facility's informed consent is combined to include anesthesia, then the type of anesthesia used should be included on that consent as well. And your anesthesiologist should obviously sign off on the bottom of it, being that they should be discussing with the patient any risks and benefits to that. And the last requirement in documentation is a discharge diagnosis and disposition. I typically look for a brief progress note or an order from the physician regarding discharging information. It can be added to the op report. And if the patient is transferred to a higher level of care, then I'm expecting to see a full discharge summary for that transfer. This should not be at all confused with the standard discharge instructions that are sent home with the patient. In those discharge instructions, you're sending home the type of procedure that they had, what they should expect for outcome, any infection signs they should be looking for. It should also include any meds that they're being sent home on, pain meds, antibiotics, and when to follow up with their physician. Next slide. And then these are the citations that you can get for missing any of these elements. A standard level non-compliance citation, that would be the missing of one element in one record. Typically, you're not going to get many of these. The big thing I see is the condition level citation. That's where you have multiple requirements missing in one record or consistently missing documentation through multiple medical records. You have a physician who tends to be non-compliant with discharge orders. If those are missing through all of his records, you're going to get a condition level non-compliance citation. And payers and accrediting agencies don't care why something is missing. They just know it's missing. Next slide. Importantly, signature requirements. All documents completed by the physician need to be signed by the physician. Today's EHRs, they record the date and time the author completed that entry. It doesn't tend to be a huge issue now, unless, of course, the physician just never signs it. I see that quite a bit. They will type up all of their HEP, they will do their op report, they will enter all of their orders in, and then they just leave them hanging to never be signed. If it's a paper document and that signature is illegible, your facility should have a signature log or attestation process that can be used to identify that signature for any payers or agencies that come along and want to see that. When a document is missing a signature and the provider signs later, they cannot backdate that to the date of service. They need to put today's date or the date that they signed. Like I said, EHRs are going to catch that. There typically is no issue with backdating. It just can't be done. Next slide, please. We've reviewed many of these common missing data elements already. There are a couple other routinely missing documentation points that I would come across, and those would be the pre and post procedure calls to the patient. I see that it's specifically the post-procedure calls. Those should be done within 48 to 72 hours after procedure, after your patient goes home. I see that either A, doesn't happen at all, or it's 7, 10, 14 days later. And med reconciliations. Any meds given within your facility need to be reconciled. Any meds that come in with the patient and go home with the patient, we need to reconcile all of those meds to make sure that we have everything correct. Next slide. And it's fairly easy to make sure that your facility is in compliance with medical records. And the easiest thing is just to have policies and procedures in place. That also includes up-to-date and clearly defined medical staff rules, regs, and bylaws. When you author these policies and procedures, you should first have a firm understanding of the medical records documentation requirements for your area and your state, and of course, federal level. You can network with your colleagues at other ASCs, at other facilities to discuss what their documentation practices might be. Reach out to your region's Health Information Management Association. Every state has a HEMA association full of medical record and coding experts, and many states have even regions within their state. And they are a great source for information regarding documentation and coding and billing practices. You should always keep up with your CMS and state regulations and monitor for any changes or any new additions. Educate your staff and providers on those documentation requirements, and then hold them accountable. Just because they are only in your facility once or twice a month does not give them a pass to be delinquent on their chart completion. Regulatory agencies don't care why the record is not complete in 30 days. They just know it's not complete. Excuses to them, they don't hear it. And lastly, do not make policies that you are not going to enforce or follow. Next slide. Once you have that policy in place, you need to audit it for compliance and efficiency and effectiveness. Look for root causes of why documentation isn't being completed. Maybe your templates for your physicians are set up wrong. Maybe you have an EHR training issue, you need to retrain your providers and your staff on new components, new upgrades. By identifying and correcting those issues early, you're going to mitigate much of the risk to non-compliance down the road. And GHA is here to help you with that documentation auditing to make sure your facility is in compliance and maintains that compliance. Next slide. So this is one of the auditing tools that we use at GHA when conducting our medical record reviews. I will always share my findings with you and your team. Along with my findings, I give recommendations and supporting guidelines that support that findings. And we do this for many clients. So feel free to reach out to us at GHA if you'd like to learn more about our medical record review process. Next slide. One last note before I pass this over to Alicia. New York has a requirement that states that ASCs and their diagnostic and treatment centers must ensure that their medical records supervisor, which would be someone who is not already credentialed with an RHIA or an RHIT credential, receive a consult from a qualified medical record practitioner on their medical records system and records. A medical record practitioner is a medical record expert who holds either the RHIA or the RHIT credential. The A would be your administrator and the T is your technician. It's a difference between a 4-year degree and a 2-year degree. Both of those credentials are highly experts in all areas of medical records and coding and billing. And GHA provides that service to ASCs and their diagnostic and treatment centers to ensure that this requirement is met. And we'd love to work with your team to make sure that this is the easiest requirement that you will meet all year. Off to you, Alicia.
Awesome. I think Andrew's muted. Anything you want to say?
I'm sorry, I was on mute, my bad. Before we go, Michelle, thank you, that was excellent. Before we go on to Alicia, something I neglected to say, if you look at the bottom of your Zoom screen, it says question and answers. You can click on that and put your questions in about anything that Michelle said or Alicia's about to say, and we'll try to get some of them during the question and answers at the end. We already have some questions. So excellent. And now Alicia, the president of GHA, will take us through coding strategies and best practices.
Thank you. Yeah, next slide, please. So we really want to thank everybody for tuning in today. And as you can tell, we are very passionate about medical records and the importance of that, both for patient care, continuity of care, as Michelle was saying, meeting those accreditation and regulatory requirements, and then into the next phase of how those medical records play in rolls into your revenue cycle. We know, all of us in the industry know how complex the revenue cycle can be, right? We talk about coding and we talk about, all the different components of that, but the revenue cycle within itself is really like an onion if you think about it. And as we peel back all the layers of the onion, which make up the revenue cycle, there are so many, each layer has its own nuances that allow for risks and opportunities. And today we're going to talk about some coding strategies, because that is one layer within the entire revenue cycle that poses very high risk, but also poses opportunities for us as well. I just want to talk a little bit about that and the complexities of some of the additional layers in the revenue cycle, right? Nowadays, we have increased patient financial responsibilities, fee transparency requirements. Again, accurate coding is one piece of that. And then managing denials and rejections. You have to deal with payment collections. So you can see the layers go well beyond, eligibility verification. The next thing I really want to talk about as far as the revenue cycle and coding, look, the revenue cycle is the artery of our organizations, right? That's how you're going to get paid. That's how you're going to stay in business and be able to provide services to your patients. It is so critical to use trained and experienced staff on your coding team and your billing team. We say, a coder is not really just a coder, right? When we get certified in coding, which, for me was many, many moons ago, and there's been a lot of advances since then, but we all learn a little bit about a lot of areas. So just because you're a certified coder doesn't mean you have expertise in your specific niche area, which we think is just really critical. So how do you know if someone you're hiring has expertise in your area? During your interview process, you can quiz them, give them a little test their knowledge around your specific area. And then once you have your team in place, it's so critical to put a quality assurance program in place to be monitoring, proficiency and testing the staff that you have to make sure that they are up to date and accurate. And that leads me to your responsibility from an administrator standpoint. You should be making sure that your staff, your coders and your billers have the tools they need to be effective and the continuing education that's required to stay up to date with all of the changes that are going on in the industry. And we all know that the one constant thing in healthcare is change, right? We're going to talk about this today, and tomorrow there could be changes. Michelle talked very specifically about some controls as part of your compliance program that you can implement in your organization to help you to ensure compliance, mitigate your risk, and then also make sure from a billing perspective that you're capturing all the opportunities that you should be. And the structure on the revenue cycle side is very similar, right? You should be having those policies and procedures. Why? Because it standardizes the information that all your staff should be on the same page. You should be educating everyone, right? Everyone needs to be up to date. And we're going to talk a little bit about not just educating your staff, your coders, your billers, but how your physicians and your providers and your nurses all also need to have education for whatever component they're contributing to that medical record. Risk analysis, right? Once the former OIG Inspector General at a compliance seminar said to us one time, if you're not really sure where to look to identify your risks, follow the money, because the revenue cycle in your organization poses very high risk levels. So having a revenue cycle integrity, doing risk analysis is really then going to help you drive your audit work plan. You can have all the controls that you want in place, and if you're not auditing and monitoring and testing them for effectiveness, they might all be for naught, right? So that is a very critical component, specifically on the revenue cycle side. As Andrew knows, we talk about so often, like so many of the providers and the centers and the facilities that we work with, a lot of the issues that we are helping them with are preventable. So we're always saying, do this proactive, get out in front of this, identify issues early, and then mitigate the risk of having, bigger problems down the line. One thing I just want, we all know that payers have different rules, they have different requirements. Be mindful that, we're talking about Medicare and the federal, Advantage care plans, but commercial plans and policies may have their own rules around claim submission and what's required. Next slide. All right, so one additional layer of that onion in the revenue cycle is submitting clean claims, right? We want to make sure the claims are going out the door clean. And unfortunately, we see so much of that focus on the clean claim, but then when the claim getting the claims out the door, they don't go out clean. And then when you have issues on the back end, we don't tend to see a lot of resources available to follow up on denials and rejections. So when you're submitting the claim, you should be answering the following questions. Who provided the service? who the patient was, and I can't tell you how many times we see inaccurate information as to who actually rendered the service. So really important. And then the what, the where, and the why are all communicated to the health plan through codes. So it's going to be critical to make sure that you understand the coding processes, the modifiers that are all appropriate and applicable for the services that you're rendering, the procedures you're doing, and your type of facility. Again, location, making sure that the place of service is accurate. The data service, be mindful that if documentation, like Michelle said, should not be being done later on down the line, that the date of service of all entries in the medical record are appropriate to the date of the procedure. And then the reason for the services that they were performed. Every year, October, the new ICD-10 codes come out, the guidelines change, codes get deleted, codes get added. Really critical to keep your staff and providers up to date on those changes, because that is how you communicate medical necessity for the services that you're seeking reimbursement. Next slide. Okay, we talk about medical necessity. We all know services that aren't medically necessary don't get reimbursed by the health plans. And we just want, we understand that most all procedures that are performed in your facilities require prior authorization. But we also know, and you should be mindful, that getting a prior authorization is not a guarantee of payment. And we see this many times. And anyone who's ever attended any of my sessions know I always say that it's not about getting paid, it's about staying paid. And just because you get paid doesn't necessarily mean you should have, right? So really important, making sure that the documentation is complete, accurate, timely. As Michelle said, you're going to hear that a lot in our presentation. We just can't stress enough the importance of that medical record, right? It's your backup of saying, hey, this is what I did, this is why I did it, and making sure the documentation is there to support it. Signs, symptoms, complaints, really the facts have to be there to substantiate, in the patient's medical record, the care provided. Next slide, please. With that being said, the reason that we're saying all of this needs to be there, yes, first for patient care, continuity of care is critical, telling the patient's story, but payers have contractual obligations to their enrollees, and they can, and they do, and they will request documentation. So don't find yourself in a situation that you're now having a record request, making sure that your notes are signed. The payers want to know, they're looking, hey, was the treatment appropriate to the patient's condition? Was it everything medically necessary? Is it coded correctly? That's a huge strip in that onion, right? A layer in that onion, that's a very big piece of that. And then that they're reported correctly for the site of service. Next slide. Okay, problems occur, we know, when dictation is incomplete and unclear, right? You can't bill for a 3-hour complex surgery and have one paragraph in the record. So this is where we're really going to put the plug in that not just your coding staff have to be experts, but your doctors have to be educated on what is required to be put in that documentation to give your revenue cycle team the information that they need to be able to, 1, mitigate your risk and code correctly, and 2, capture all opportunities for reimbursement that are available. So a physician or a provider just cannot rely on their coders or even an insurance adjudicator to be aware of what's happening in these procedures unless they actually explain it fully, detailed, and include it in their op report. Okay, next slide. All right. We put together, I know we're really short on time, but I just want to take you through these elements. We put together a checklist that can help you make sure that your opera notes are comprehensive, including everything that they should have in them. Coders, we always teach our coders, you should not be coding from the pre and post operative diagnosis. The coding happens from the body of the report note, right? So providers should be educated that they really need to be documenting the seriousness of the circumstances, of the procedures, using terms like surgery was difficult, it was complicated, there were unusual circumstances, we encountered abnormal anatomy, why did it take longer than normal? Was the provider, did he have extensive reason for lysis of adhesions? And then also including terms like, hey, it was ordinary, uncomplicated, and simple. So it's essential, and we'll look in the next slide as to why so much of this information is required for accurate coding. So next slide, please. Okay. So another thing we want to talk about, we see this all the time across industry-wide, modifiers are troublemakers when it comes to revenue integrity, getting audited, putting yourself at risk. So it's really critical to make sure that if you are appending modifiers or you're required to append modifiers, what do? They really just provide additional information to the health plan about that claim line and the services that are being rendered. So be mindful, not all modifiers are used in every setting. So make sure that the modifiers you're picking are appropriate for you and your facility. Again, documenting the length of time that was spent on each procedure house should be specified, right? Length of all repairs. When we talk about selecting the right codes, we know that this is critical information. The doctors need to be putting in the body of the note, was the repair simple, intermediate, complex? All of these things drive you to the appropriate code for the services being rendered. And then just again, the layers of skin, whether it's subcutaneous tissue down to the bone. In some cases, the depth of involvement is really going to determine what code you're selecting for the procedure. And then again, lesions, excisions, there's very specific guidelines and requirements about how those codes are picked. So next slide. Okay, we talked about prolonged attendance, should be documented. And then any unusual circumstances, right? Special instruments or aids like a microscope, fluoroscopic guidance, all of that should be documented. The modifiers that are applicable when the patient or procedure requires a surgical team or an assistant surgeon. We see a lot of errors in that area as far as the documentation when there is a primary surgeon and an assistant surgeon from a coding and reimbursement perspective. And then again, the time, right? Operating microscope, ultrasound guidance, all of that needs to be documented. Next. Okay, I think we're coming in. We're sliding into the finish line here. I don't know, Andrew, if you want to, we can just talk about some of the.
Why don't we'll do these during the discussion. Okay.
Sure.
Okay. So thanks. Some of you put your questions into the Q&A. Some of you texted me. So let me start with some of these. Michelle, how would you respond to an ASC that says, listen, the anesthesia group, we don't control them and they do whatever they do. So you had all of these things that an anesthesia record has to do, but they're not us. Does that get you out from under?
No, it doesn't. When you sign them on and they accept privileges and you give them privileges at your facility, they are accepting your rules and regs and bylaws that are put forth to include your policies and procedures regarding documentation. They do not get a pass, no.
Okay. Somebody asked, how often do you have to do a licensed medical review?
I would say annually, more frequently if there are multiple findings in your facility of documentation concerns.
Okay, so annual. Okay. And of course, if they wanted to pay GHA to do it every day, we would find a way to do that.
Well,
Sure.
and I also want to echo onto that as far as coding purposes, right? You should establish your benchmark and then implement your protocol of how frequently based on provider scoring on the scoring.
Okay, and actually, for the New York providers, our program is set up to be an annual review. But okay, Alicia, let me pick on you. You mentioned EHRs. Can you give just two quick examples of where they're bad? Obviously, we know why they're good, but when can an EHR be bad? It sounds like the beginning of a Netflix.
So we know the big thing about EHRs is making sure you have proper implementation and training. I think we see a lot of risk in the area of templates that are driving documentation that don't allow for customization. So things that are copy pasted forward, as Michelle mentioned, cloning. The health plans are really, cracking down on that and taking away credit from providers when they see a lot of that cloning. So that's a big risk area.
Okay, cloning. All right, Michelle, this is like the game show. The top three problems you see I know you went through a lot of problems, but for those, somebody texted me, I'm overwhelmed. So what would you expect in your average AC to be the top three medical record problems that you would see?
That would be missing and incomplete documentation, missing signatures. I see a lot of general consents to treat and HIPAA consents, patient rights consents that aren't updated regularly. Annually is the benchmark across the nation for updating those in an ASC or primary care diagnostic treatment centers facilities. And then the other one that I see is multiple EHRs or multiple records in different EHRs or paper and not knowing where your paper is and having some of it here and some of it there.
Right. So,
The three.
I know Alicia and I have done this when we've fought against payers. What happens is they ask for 50 records and they're only pulling it from one of those medical records.
Mm-hmm.
And now we're up on appeal, which is a much more difficult thing to do, just from that one perspective. Also from a malpractice perspective, you could miss the allergies that's in one and all these other different problems. So I'm with you on that. But let me ask you both a political question, because somebody just texted me, my doctors don't care. Okay, so what do you say to the busy, I don't know, let's pick an orthopedic surgeon, you're going to go up to him and say, hey, you're not completing this or that, or the GI where the pathology report comes in and doesn't find its way within 30 days to that. How can we get doctors, maybe through self-interest, or I don't know, you tell me, to build a culture where they're going to be more compliant?
I have had plenty of doctors who will avoid me specifically at all costs, knowing that I'm going to come for them to just sign this. I just need you to sign this. I've had doctors remove plates and such from a patient and then not document it just because, their excuse is, well, let's just not bill for it. It's not a big deal. Well, it's not just billing for it. It's what happens when that patient shows up at another healthcare facility and they request records and they saw that this patient had this device in their body a year ago and now they don't, and they don't know where it went or how it was removed or who even did it. That's why we need to document everything for the patient's safety, and we just cannot not billing for procedures because we just don't want to document.
Well, let me add to that as a way of getting the doctors to be compliant. I have defended more than one doctor under a licensure issue where a patient complains that X was done to them. It's not in the medical record, and the doctor's not denying that he did it, but it's almost an of course I can do anything, but it's almost an indefensible position. What do I say? We forgot, oops. So if the doctor doesn't do it and the patient complains, it could lead to suspension of your license, because the license, and I do it in 3 different states, the licensing police go crazy on that. So maybe that can get them. Okay.
And then Andrew, one thing in addition to that is that that's not a small thing, but even one inconsistency or missing component of the record then raises the question of integrity of the entire record.
Right.
So,
That's exactly right. So that's a good segue, Alicia, to a question for you. Again, we're looking at your experience. Would you say that from a coding perspective, are the physician, because I find a lot of physicians feel that their records in their office are really what matters. So maybe I'm giving away the answer, but you could say, no, that's not been my experience. Are the record keeping usually better in the ASC, or is it better in the physician's office, or the same?
So tough, because we're always fighting on both sides for proactive processes. I think maybe, in the AmSurg centers, because they're so much more highly regulated and have accredited, they're looked at more frequently than physician practices. I would say that there's probably processes, although we see a lot of issues specifically with the hybrid records.
Okay.
It's a tough question. From both perspectives, we hear a lot like, why wasn't I doing that? So I don't know. It's tough to say.
All right, that's a jump ball. Fine. Michelle, I assume that in your career you've supported people who've gone through, whether it's AAA or whatever, through the review process. Do you find that the reviewers, are they getting more exacting on the medical records, less, or the same? Like, you went through all the CMS requirements. Is that a big issue typically on an annual, on a review when they come in?
That they're missing documentation
No,
that's
no, no.
required?
In other words, medical records in general, is that a focus of the reviewers?
Yes. Yes. Oh, when I have a surveyor come into a facility, and I have sat through surveys from all sorts, from state to CMS to Joint Commission to just, normal, your accrediting agencies for post-acute and ASCs. I will sit hours with them through a medical record review, and they will go, show me where the vitals are. Show me where this H&P came from. Can you show me what encounter the post or the pre-H&P came out of, and what was that date? I have even answered questions from a surveyor asking who the witness was on a consent form.
Wow. Well, I will say this too, and there were two people who registered from the seminar that I went for personally for medical records, but I see this often. I'm for medical services. I see this often. The receptionist will take the place you're supposed to sign and turn it to you, and you sign it, but you don't see the record you're signing it to. Right? And now, as a lawyer, it freaks me out. I don't like to sign anything. But because it's an occupational hazard, that's why I don't think they like when I come in for treatment. I don't even know how that could be legal. Like, I mean, you're signing a consent that you aren't even being given a copy of. Now, I don't know whether Alicia, you or Michelle come in, if you've ever experienced that, but I'm seeing it more and more that the systems are supposed to be easy. You just sign it, but you don't. And then when I ask, they're like, well, we can give you a copy of what you just signed. But that can't be informed consent because I don't know what I just signed.
So the informed consent should always be up on the wall right next to that patient, in a big sign. That is a regulation. And then there should always be a paper copy available for the patient to read before they sign. That falls back on your patient access or registration departments to make sure that they do that correctly.
Yeah, I just think that the EHR systems are not being designed with that. But okay, so we are clearly out of time. I want to thank the GHA team, Michelle Vander Ark and Alicia, our president. You could go to the next slide. If you want to reach out to us, we will be sending around the slides. Here are some references. You'll get that if you want to read through some really boring stuff. But if you want to reach out to us, go to the next slide, please. You will, no, one more. There we are. There's Alicia's phone number, and you can get her. And there's Michelle. And we're here to help you with all of your needs. And we barely lost anybody through the full hour, 15 minutes over. So hopefully that's a good sign. Thank you very much for joining us, and have a great day from GHA. Thank you.